So let's wait just a minute so we see our participants starting to join. So normally at about 15 minutes after the hour is when we start getting critical mass. So I will just start by saying that this work wouldn't be possible unless it were for the amazing volunteer leaders that we have from across the state, from fantastic medical groups, health plans, academic medical centers, public health, and patient enthusiasts. So we have great support from the UC Berkeley School of Public Health Leadership, which is our mothership. And we also have support from the California Department of Public Health, the Los Angeles Department of Public Health, Blue Shield of California, the Stroke Awareness Foundation right there in Santa Clara County where you are, Kate, and the University of California, San Francisco, the American College of Cardiology. Johnson & Johnson has been with us since 2008. Genentech, Boehringer Ingelheim, Novo Nordisk, Amarin, and the Santa Clara Health Trust. I don't know if you know them, Kate, but they actually have a program where they bring healthy meals to heart failure patients, which I think is just brilliant. And we'd love to expand on that. So with that, next slide, please. Most of you know me. I've been co-founder of this program, which started on my desk way back when I was a regulator at the Department of Managed Healthcare many eons ago, looking at lots of quality improvement data and working at the request of the governor's office and the director of the Department of Managed Healthcare to use publicly available data to drive quality improvement. Next slide, please. So my co-founder was the chief lawyer in health for the state of California, Warren Barnes. He no longer participates, but he's a lovely advisor to the program. And he responded when some of the medical groups said, is it legal for us to all be sitting in this room together working on quality improvement? And he came up with our mantra, which is, we compete against disease and not each other. And he's sort of the godfather of our program. Next slide, please. So our leadership will be joining us, the full leadership for our Bay Area group in the next few minutes. I just want to emphasize that our three core goals are driving good control of cholesterol, blood pressure, and blood sugar. And we're going to learn so much from our wonderful speakers today, Dr. Kate Collings and Dr. Ken Fujioka, about great approaches to doing that. Next slide, please. So we will hear in this first hour from Kate Collings, the president of the American College of Lifestyle Medicine. And in the second hour, we'll be hearing from Ken Fujioka, the director of Scripps Clinic for Nutrition and Metabolic Research. And then we'll have a nice open discussion at the end for people who want to turn their cameras on and just participate in a free-flowing discussion from 6 to 6:30. That's completely optional. Next slide, please. We drive quality improvement through evidence-based practices, and we hear different approaches to that each time we gather, which is twice a month now by Zoom. And I'm happy to go into that further, but I think today's program is really at the apex of our right care triangle of promising interventions, which is around patient activation, and certainly also includes protocols and other evidence-based methodology. Next slide, please. So we drive quality improvement through understanding where we are. And we'd love to have more timely data than we do, but this is the data that is published by the state's Office of the Patient Advocate within the Health and Human Services Agency. So I want to just do a shout out to Ed Yu, Chief Quality Officer for Palo Alto Medical Foundation, for helping us lead the way in our metrics. Next slide, please. So today you'll see that in the Santa Clara County area, where Palo Alto Medical Foundation has its flagship Palo Alto Medical Group has the best control of blood sugar in the Santa Clara County. So there's lots of back and forth between our wonderful leaders here. Co-opetition is what we like to call it. And next slide, please. With that, I'm going to turn the meeting over to our wonderful co-chair, Dr. Evelyn Stock, who joins us from her hospital work at the University of California, San Francisco, where she is today performing cardiology procedures. So with that, Dr. Stock, I will hand the meeting over to you to introduce Dr. Kate Collings. Thanks everybody for being here.
Hello there. I'm Evelyn Stock. I'm co-chair of the Silicon Valley University of Best Practices Right Care Initiative, and I am delighted to see you all today and introduce our wonderful speakers. We are so thrilled at the Right Care Initiative that we get a chance to hear from this powerhouse physician who is bringing to us a very, very important topic that focuses on what healthcare is supposed to be, focusing on the cause of disease, identifying and eradicating, hopefully after we hear Dr. Collings' wonderful talk, of get ideas and how to execute lifestyle interventions. She is a dual certified physician in lifestyle medicine and cardiology. She is the director of lifestyle medicine and president-elect of the American College of Lifestyle Medicine. She has been part of El Camino Health Community for 25 years as a respected clinical cardiologist who now focuses exclusively on lifestyle medicine and directing the lifestyle medicine services. She holds graduate degrees in multiple specialties, including exercise physiology, culinary and wellness coaching, and she has received education from the University of California, Davis, the University of Wisconsin, Madison, and Stanford University Medical Center. So we are delighted to have you, Dr. Collins, and can't wait to have you show us and direct our attention to how to improve our health by learning the secrets of cooking and nutrition while we're at it. So I'll hand it over to you, Dr. Collins.
Thank you. I appreciate that. So let me go, I guess it's on my screen now. Or let me share screen. All right. Can everybody see this now?
Yes, looks
Okay.
good. Sound is good.
Great. So yes, I'm delighted to be here and have a chance to speak with you all about lifestyle medicine and culinary medicine because I see them as additional paths to help manage chronic lifestyle related conditions. Ooh, my slides are not advancing. Maybe I need to advance them this way. Okay, I found another way. So the objective today for me is to define lifestyle medicine and help you understand why lifestyle medicine is so important now. I'm going to provide some very basic review of research and outcomes of lifestyle medicine type programs. I'll touch on what are some of the unique methods that are used in lifestyle medicine clinical practice, including those that I use in my own practice. And I will then go on to the latter portion of the talk to define culinary medicine and show you how it's used in both provider and patient education, and then hopefully leave you with a lot of educational resources for lifestyle medicine and culinary medicine. And I won't be providing research references on the slides per se, but I have the references at the tail end of the presentation. I'm happy to send those to you. I don't have any financial disclosures to report, unfortunately. And a lot of my slides have ACLM, as well as a few that have Stanford Medicine as on the logos, because they have been co-designed by myself and by Dr. Michelle Hauser at Stanford, and she has agreed to share them. So I have a lot to talk about, and I'm going to go pretty fast now that I've figured out how to advance the slides right. So first of all, lifestyle medicine defined. So there is a formal definition in lifestyle medicine, and it is the use of evidence-based therapeutic approaches centered around 6 pillars, including a whole food, plant-predominant eating pattern, regular physical activity, attention to restorative sleep and stress management, avoidance of risky substances, and positive social connection, delivered ideally by clinicians trained and certified in the field. And the aim is to not only prevent, but oftentimes treat, and when possible, reverse chronic disease. And when I first explored lifestyle medicine, it was important for me to understand the distinction between lifestyle medicine and other medical disciplines. And I had heard about functional medicine, I had heard about integrative medicine. I was concerned about things being alternative in nature. And so while these are not hard, lines, people, I believe that medicine is both a science as well as an art in terms of how we heal our patients. And sometimes there is a bleeding of these edges. But for the purposes of putting some definition to these, lifestyle medicine is not preventive medicine. It's a lot of people grew out of the preventive medicine discipline and came into lifestyle medicine. And preventive medicine is more aligned with public health. It's elevated the importance of early detection and screening and environmental safety and so forth. Allopathic medicine is what most of us have been trained in. Think about that as conventional medicine. We look at chief complaints, we're symptom focused, and we go after these chief complaints with typically with diagnostics and pharmacological and procedural kinds of solutions. Functional medicine is often confused with lifestyle medicine, but it is in many ways quite different. Many functional medicine physicians are interested in novel diagnostic blood work, and they are more likely, not exclusively, to use nutraceuticals and supplements and so forth. And so that's not really the focus of lifestyle medicine. And then when it comes to integrative medicine, this is more often a blend of complementary approaches, if you will, east-west. They take along with conventional approaches, and they take a whole person approach to care, which is also in kind with lifestyle medicine. But integrative medicine and lifestyle medicine are not one and the same. And so in lifestyle medicine, the focus is really using a lifestyle first approach when possible to treat and reverse the existing conditions by looking at the root causes. It does require that the patient is engaged, and it offers the patient the ability through their everyday lifestyle habits to be the locus of control of much of their health destiny. And I would say that, lifestyle medicine is not a lifestyle only approach. It's not rigid like that. There's certainly lifestyle medicine can be applied as a lifestyle plus medication approach, and the two are not exclusionary. So why now, and why is lifestyle medicine so important? And I know that this particular group is really enlightened to this because we've all been in the seat of seeing patients come in and out of our door and thinking to ourselves that this is really related to their lifestyle. And as it turns out, in this healthcare survey report, it's estimated that up to 80% of healthcare visits, hospitalizations, and costs are related to 8 risk behaviors, and that these drive 15 of the chronic conditions, and the ones that I know all of us in the room have seen over and over. And you are also, I think, very well enlightened into the problem with chronic disease and the chronic disease epidemic in the United States, with 6 in 10 Americans having chronic disease and 4 in 10 having 2 or more, and that this has created for us really unsustainable economics that are, promised to get quite a bit worse as we have not gained control of this increasing prevalence of particularly 2 conditions, obesity and diabetes. And so healthcare, lifestyle medicine is very much in the realm of helping to manage and treat lifestyle-related conditions, chronic conditions. This is a study that came out just recently looking at the burden of, from the US Burden of Disease collaborators, looking at the leading causes of disability. And in a companion article that looked at 195 countries, they came up with very similar results, that dietary risk is the #1 risk of disability. And if you look at the top 10 of these risks, you'll find that 7 out of 10 of them are also lifestyle related. So lifestyle medicine is also extremely relevant in a pandemic, and I often call COVID-19 a pandemic within a pandemic. And you all have watched this as well and read so much about it that the US and global statistics show over and over that the patients that suffer the gravest consequences, those with hospitalizations and deaths, really have these comorbid, largely lifestyle-related conditions. And it has certainly, shined a light on healthcare inequities and disparities as well, again, through this same lens of, chronic underlying conditions in the communities that have suffered the greatest consequences, and in the populations who have suffered the greatest consequences. So lifestyle medicine is evidence-based and clinically driven. There are nearly 57,000 references listed in PubMed with lifestyle medicine as when you put that in as a key search term. And so much of the literature, so that's just lifestyle medicine as a search term, but of course it's drawing from, the volumes of research in nutrition and in the exercise sciences, and what we know about stress and what we know about sleep as well. And so I encourage you to start by looking at some of the references I've shared in this presentation, but also going to the ACLM website, where you'll find many, many more. So lifestyle is really not a new concept, I think, for any of us in the room. There's something, nothing particularly new, because we see it, for instance, in the ACC and AHA guidelines, where it's recommended that it be intensive for young adults aged 20 to 39, and a primary intervention for metabolic syndrome at all ages. And, having practiced cardiology for 30 years, I'm not proud to say that I really felt like I could never implement this guideline during my time as a cardiologist. I just didn't have all the tools in my tool set to do that. And so very often, pharmacological means were my first and primary solution for patients. And then similarly, the American Diabetes Association recognizes lifestyle as fundamental, but all too often, metformin and other medications are prescribed before a nutritional or exercise intervention. So what's important is we have these grounding guidelines, but they're just not quite enough. And, the way I see it is lifestyle medicine, the tools that we have in this tool set are really our way of implementing what we've known all along, which is we need to take a foundational approach and help our patients first and foremost with lifestyle. So lifestyle medicine practitioners center their care around these 6 areas, the same ones that I talked about in the definition: nutrition, exercise, sleep, substance use, stress management, and social connection. So it's really very much a whole person approach to care. So I'm going to go through very quickly, just very high level, looking at these 6 pillars. And as I said, the references will be in the back. But clinicians practicing lifestyle medicine recognize the importance and attention to, all 6 pillars. But nutritional interventions often demand the most attention. And they yield the biggest benefit for our patients. So particularly through the lens of a goal for disease treatment or reversal of established disease, the balance of evidence points in the direction of using a whole food plant-based diet as the best nutritional intervention. And so much of the focus is there, but there are other plant-based dietary patterns that approximate this. So exercise is a key lifestyle medicine intervention. And, we know from the scientific guidelines, the Physical Activity Scientific Report 2018, that we have the foundational evidence to recommend general physical activity. And we know that integrating exercise is a vital sign into every patient encounter is important for assessment and exercise prescription to bring that to the table of the medical encounter. But there's also just a lot of exercise science research that I say is just left on the shelf. And we just don't really bring it into medicine. But we know so much about how to use exercise for diabetes, for hypertension, and even what I've learned recently, even to mitigate side effects of chemotherapy in people going through cancer treatments. So really important that we, take that science off the shelf and bring it into our patient encounters. And if we can't do it, that we need to use a team approach to this. So sleep is also in the realm of lifestyle medicine clinicians' interest. It's a vital pillar. We know that sleep disorders are notably associated with cardiovascular and cardiometabolic and neuropsychiatric risk. And sleep is also important because it has this multi-directional effect on the other domains of lifestyle. If people aren't sleeping, they're not going to be making good behavior change and good decisions in other aspects of their life. And that's why it's so important that this is a holistic approach to care. Stress is also just a really important part of lifestyle medicine attention, another domain that falls into those pillars. And since we know that chronic or maladaptive stress is, causes impairment across many physiological systems, and that many of the techniques that we use to manage stress have direct effects on these same systems. And then I would also just again point to the fact that if we don't attend to stress management in our patients, we're leaving something at the table, because that is also having a multi-directional effect on their capabilities to actualize other positive lifestyle behaviors. Addictive substance use is also of note in the lifestyle medicine realm. It's an important pillar to address for the same reasons that I said we need to address stress. But it's also been used in some lifestyle medicine programs I found very interesting, that programs that were primarily for addiction, many of the leaders come in through a lifestyle medicine lens and actually can really facilitate the patient's encounter in their journey to recovery. So it's an important part of the whole picture. And then last is social connection, which is so important in our COVID times, right? We know that isolation and loneliness are associated with increased morbidity and mortality in patients with established lifestyle-related disease. And we also know that it doesn't often take much, these micro moments of human connectivity that correlate with these positive physiological responses. And then I would just add that, what's key is connection is, and I know many of you who are clinicians have experienced this, but when there's a good patient and provider connection, this goes a long way to help people heal themselves. And so I would say that connectivity is an active ingredient in lifestyle medicine treatments. It's also an active ingredient with peer-to-peer support. That is really the way many patients heal, is through peer-to-peer support. So I was very, I was going to say more and more research is always going to be needed, but I was excited by this recent publication in Frontiers in Medicine that was published in December of 2020. And it was a report coming out of a summit where there were really lifestyle medicine thought leaders and subject matter experts in these various pillars, if you will. And they were all coming together to look at the current state of knowledge and where there were gaps in knowledge and provide research. They acknowledged that lifestyle medicine, these pillars on the left side of the slide that you see here, really work through probably three major mechanisms. Is through microbiome alterations, through epigenetic changes, and through cell stress and injury. And then, of course, all of those relating to inflammation, either tapping it up or tapping it down, and leading to, the commonality being multiple conditions that drive this entire thing, including, I think it's not on here, but in terms of dementia and cognitive. And there were some big thinkers in that group, who were looking at how can we use big data and bioinformatics and computational modeling, stuff I don't have a chance of understanding, but really to accelerate our understanding of lifestyle interventions and solutions. So a really great paper, if you can, it's in the references and you want to take a look at that. So one of the areas of let's take a look now at some programs, if you will, and research in programs that have woven together most of the pillars of lifestyle medicine. And this one is a study looking at patients with established type 2 diabetes that comes out of the Look Ahead research group. And this was a large study of about 4,500 patients, and they were randomized to one of two programs, either an intensive lifestyle intervention involving dietary and exercise intervention, or what was defined as usual care with diabetes support and education. And you might not be surprised to know that the lifestyle intervention patients lost more weight, had greater fitness, and were more likely to experience partial or complete remission off of diabetic medications at years 1 and 4. And so this is just an example of the difference between management of diabetes and the opportunity for a more intensified lifestyle intervention to actually create remission of the condition. And then this is a study that is really an economic analysis looking at this same premise. What if we were able to really gain remission for a lot of our patients in diabetes? And how would that pan out in terms of managing these burgeoning healthcare costs? And this was an economic analysis that came out of the UK, and they're probably amazing at this. But it amplified again this idea that we would try to aim for disease reversal or remission when we can. And they used the data that came out of what was called the DIRECT trial, which was also a diabetes remission clinical trial involving about 500 patients. And 46% of those type 2 diabetics achieved remission at year 1, and there were 36% at year 2. And the cost savings came from medication reductions. And that cost saving wasn't really seen until year 6 in the analysis. So the cost of intervention was greater than the standard usual care at year 2, but gained by year 6. And so, I did the back of the envelope thinking about this and said, well, geez, if you had a diabetic aged 55 and their life expectancy might be 13 to 21 years, if you can really get to remission in some of these patients, you can equate to several years of cost savings in terms of medications. It's just really an example and a way to think about what is possible with lifestyle interventions. So another of our lifestyle programs that's been around for a while is Intensified Cardiac Rehab, and is another example of utilizing multiple domains of lifestyle medicine to intervene in patients, in this case with established coronary disease. And much of the data for this came from Dean Ornish, but also from Pritikin and the Henry Benson programs, all that had to, provide a robust set of data that led to CMS coverage in 2010. And, as a cardiologist, I was never very wowed by or just not wowed by angiographic results. Where I got wowed, though, was, I really think of coronary disease in much more physiologic terms rather than anatomic terms solely. And so improved myocardial perfusion that was demonstrated, decreased angina, and importantly, fewer cardiac events was really what has made me feel very positive about intensified cardiac rehab. And I've been a director of a traditional cardiac rehab since 1993 until about 3 months ago. And, I built out my program to basically resemble intensified cardiac rehab because I felt that we were really missing the boat with an largely exercise only, and a little bit of education provided. The Complete Health Improvement Program is another example of a lifestyle medicine program, and it's really the first certified program through the American College of Lifestyle Medicine. There's a number of publications that have come out in this program, and both in the U.S. as well as internationally, and also in diverse populations within the U.S. And so this again is a whole person program. It embraces all the domains. And in this particular study of 1,000 patients at 30 days, the patients in the highest risk quadrant had pretty tremendous results. So these were patients with very elevated triglycerides and glucose and cholesterol and so forth. So 30-day results are nice, but we know that what we can do in 30 days is not necessarily what we can do for a life, and we really want to impart lifestyle change. So another study that they did was a much smaller study. This was, I think, less than 500 patients. And they had they came in and they had very similar 30-day results. And in this particular study, it wasn't in the design at the outset, but sometime later, they invited people to come for a free exam and to re-look at their biometrics anywhere between 3 and 5 years after they were originally seen. And in this, and so the average time was about 4 years. Those, again, with the highest risk biometrics, maintained significantly lower biometrics. And the subgroup who reported really ongoing compliance, they self-reported, yeah, I'm still following the program. They really also showed further reductions in BMI, diastolic blood pressure, and fasting sugar at 4 years. So certainly not everybody improved, certainly not everybody maintained the improvement, but nevertheless, a good solid program for lifestyle. And this is the program that I have licensed in the work that I do in my patient population as one of the programs. So let me tell you a little bit more about lifestyle medicine in practice. So most people that have been doing lifestyle medicine for a time, and I'm not one of them, I've really been only practicing this way for a couple of years, but most people that have a passion for it apply their own secret sauce, and they vary what they do, tailor their methods, I would say, to their patient population and sometimes to their insurance profile. Are they working in a safety net hospital, and what are they going to do with that? And how are they going to go out into the community? Or are they working maybe in an affluent area, and so forth? And so while there are differences, they draw from some common tools. And it's important to start with a really comprehensive lifestyle behavior assessment, because if you ask a patient how they eat, they'll oftentimes give you, I think I eat great, or I try to exercise, or any number of things that are really don't tell you a whole lot about what is actually happening. And so a comprehensive lifestyle behavior assessment that can be done, through a tool found on ACLM website or acquired through a digital means, which is what I've chosen to do. Not always, but often it's a lifestyle medicine team of specialists. So there's coaching, there's a nutritionist, there's an exercise specialist. I favor this just because I think that it's a nice experience and a really cohesive experience, and with multiple touch points for a given individual. And then most practitioners use novel methods such as shared medical appointments or culinary medicine, which I'll talk about in a few minutes, or digital health tools. Some of them will add remote patient monitoring as an additional way for gaining some reimbursement for the additional time that they put into these patients to really fine tune their lifestyle. And, many, I think, and I agree with it, many people go into lifestyle medicine and use behavioral psychology. They get a firm understanding of that and a firm understanding of coaching psychology. So let me tell you a little bit about what I've been doing. My program is really very young. I've only been working on this within this also very young system, El Camino Health, since January of 2019. So a lot of effort has gone into just creating awareness, making sure that people understand that this program is not a wellness program and it's not alternative medicine. It's really, really want to get at-risk patients. And so, a lot of physician education, a lot of marketing and messaging that's become really important. But we start all of our patients with a lifestyle medicine MD consult, just like a cardiology consult, but in this situation, they're seeing me for lifestyle medicine. And then we take a deep dive into understanding their lifestyle patterns, and I'll show you the tech-enabled platform that we use. And, an important thing is to first enlighten patients to the fact, without shaming them, obviously, but to enlighten them about how important the lifestyle patterns are to the medical conditions that they're feeling, but also create a good connection on how we're going to work together to meet their goals and what we know should be their medical goals along with that. And we offer one-to-one lifestyle care. We call that our lifestyle medicine team care. And we use that for patients that we can get a nutritional consult on, their insurance will allow us to use our nutritionist. And then we just pro bono our exercise specialist and our coach, because we don't have any codes for that. This allows us to have multiple touch points and work it within a patient's insurance model. But we also have licensed the CHIP program, the Complete Health Improvement Program. That is an out-of-pocket cost, and we have not been able to actualize that into a shared medical appointment, despite my efforts and the gray hairs that I have achieved as a result of that. But it's been now taken up. We get about 50% of our patients come from, our patients or community that hear about it, and about 50% come through as employees of the hospital or our medical clinic. And then again, we do use a team and a coaching approach to everything in terms of our mindset and how we approach patients. We facilitate with the meal planning platform, and I'll show you that in a second. Again, we have our lifestyle assessment and tracking platform. It's also on a phone app. And I would say when it comes to tech, we love tech to think about it being scalable. What I would say it is augments, but it doesn't really take away the importance of the human connection. I don't, now having really lived it and played it with it for the 2 years, some patients are just not engaging with the tech aspects, and we still need to provide them care. And then we do our culinary medicine cooking classes. We also have our lunchtime with lifestyle medicine experts. These are just sort of not the whole program, but a way to augment and facilitate people's knowledge and engagement. This is our interactive lifestyle platform and app. We licensed HealthSnap. The research to support this came out of the University of Miami, and was validated to the degree that it was validated in their employees and in the student population. This is just one page of about 8 pages. And I like it because it's a picture tells 1,000 words sometimes to patients, when they can see where they stand in terms of normative data. They're kind of used to that. They've got they know what the reference ranges are. They're in or out of their blood ranges and so forth. And now they see them being in or out of reference norms as it relates to lifestyle. And again, this is just one of 8 pages. This is our customized meal planning app. This is called Lighter or Lighter Pro. And our nutritionist sets the patient up with a personal profile that's customized to their cooking abilities, their taste profiles, how many people they're cooking for, and their budget as well. And then here's the smartphone app. And this is our lifestyle medicine learning hub that we had, and then we now is a vaccination clinic. So I'm sad to say that we had to convert this to just really a mass vaccination center. And of course, our culinary classes have gone into virtual Zoom and so forth. But when we get back, we'll be back in this lovely setting, a nice large area where we do a pop-up kitchen and we have all our equipment in there. So now let's talk about culinary medicine. And starting with, hold on one second. Yeah, starting with, what do we know about the trends in US home food preparation and where is that importance? And so, first and foremost, we know that time spent in the kitchen actually correlates with mortality. We can't get the nutrition that we need and take out or eat out food. And so it's really important to know just that alone. Getting people into the kitchen will improve or decrease their mortality. And yet there's a trend here where there's a decrease in home cooking activities. So this is a quote from Wendell Berry that really, I think, says the state of culinary health and literacy that we're faced with right now. We have an environment, cultural norms, and sort of a built food environment that is at odds with people making healthy food choices, easy food choices. And so the quote by the agriculturalist and author Wendell Berry really says it well, that people are essentially fed by the food industry, which despite their marketing and their packaging, really pay no substantive attention to health. And yet people are treated by the health industry, which if you think about how much time we're allowed to talk about nutrition or reimbursement or the ability to refer patients for nutritional counseling, essentially pays little or no attention to food. So we really are at odds with where we need to be. And so culinary medicine is an evidence-based field. It really brings together, the science of nutrition and the culinary knowledge, the art of cooking, to assist patients in maintaining their health and preventing and treating disease. And Dr. Michelle Hauser, I should say, from Stanford has been also says that culinary medicine is really teaching people to make healthy food unapologetically delicious. And I love that quote. And I say it all the time because really the goal is to nab people with taste and change their mind about is healthy eating tasteless eating or is healthy eating really unapologetically delicious. So she also shows the difference between nutritional education versus culinary medicine in this slide. So traditional nutrition might teach to the left side of the slide, showing that the molecular mechanisms of iron in the body and discuss heme and non-heme sources, leading to a recommendation for red meat or iron supplements. But culinary medicine, on the other hand, teaches to the right side of this slide, really showing that getting a wide variety of healthful foods, whole grains, produce, seeds, nuts, and legumes would provide plenty of iron from the sources, in this case, kale and figs, and combining them with vitamin C rich foods for increasing their absorption, in this case, like the particular vinaigrette here, a citrus vinaigrette, and the pomegranate seeds. And the benefits of skill-based culinary medicine are many, and there's not large data sets to support this, as you might imagine, but smaller studies I think consistently show what we would think would be good common sense, which is, when you teach people to be comfortable and confident in their cooking and they understand why they're doing it, they'll spend more time, they'll have a better attitude, they'll eat better, and that will translate to health outcomes. In that, if dietary risk is the number one risk, it's going to translate to improved health outcomes. And that's been shown as well in type 2 diabetes. And there's been, a lot of articles on relating to the poor state of nutrition in medical schools. And culinary medicine is just really an attractive way of bringing as a vehicle for nutrition education for clinicians. So culinary medicine can be broadly applied. I'm going to show you what Dr. Hauser has done at Stanford and let you know about a few other people, but that are doing this in medical education. But it's also, easily adapted to patient education. That's how I'm using it. Community education as well. It's a very, I would say, connected way to bring people together to really learn about nutrition in a really positive way. So Dr. Hauser's program is called The Doctor is in the Kitchen. She runs and has for a few years a quarter-long elective for medical students. I think they're third or fourth year medical students. These are evening sessions. They're 2 hours. She has the students do a little bit of pre-work and videos and readings, and then about an hour and a half of hands-on teaching. She has a chef there herself, and oftentimes another chef MD, and she has faculty people join to help. And I've helped in this a couple different quarters for her. And then afterwards, the students get together, they have a dinner discussion, they do a little bit of role playing about how they counsel and patients. And then they all bring something for a final potluck. It's been really successful. And she has collected some data, and she's looked at the outcomes in the enrolled students and those that were waitlisted. So it was a randomization, and she has a pre-class survey, and that's Dr. Hauser right there, and a post-class survey. And so she was able to show that there were significant improvements made by the students in what you would think in their culinary techniques and how they use a knife and how they cook, and learning how to make healthy soups and desserts and things like that, but also in their personal habits and in increasing the number of servings of fruit and vegetables and transitioning to healthy snacks. And that's not easy in medical students, right? Because boy, we bring them a lot of food that isn't healthy over the years of their training. And feeling confident is perhaps one of the most valuable parts about culinary medicine when you apply this to clinicians, is that we know that physicians who embrace lifestyle personally are more likely to coach and counsel and at least open the questions for patients in terms of lifestyles, and similarly in terms of physicians that are confident in the kitchen become people that talk about food and are confident to counsel their patients and bring this into the medical encounter. So other culinary programs that are in action, there's a MedStar Health Fresh, which is called Fresh and Savory in Washington, D.C. That's led by Dr. Terry Stone. She uses a pop-up kitchen, and she does embed this in a shared medical appointment model. So that's insurance-based, and that's wonderful. Dr. Christy Arts at Spectrum in Grand Rapids, Michigan, has an amazing dedicated standalone teaching kitchen. The real estate there apparently is not as expensive as we have here in California. So she runs shared medical appointments with Culinary Medicine. She also runs CHIP there and other shared medical appointments in lifestyle medicine. And Christy was originally an ER doc. I think she probably does some ER shifts now as well. Kaiser, right in our area, Dr. Linda Hsu runs culinary medicine classes. She calls them the Thrive Kitchen. I've also helped her and gained her methodology, if you will. She has a pop-up kitchen, not a dedicated space. And yesterday on my doorstep, I had a cookbook delivered to me from her just a beautiful cookbook called The Spice Book Kitchen that she just published. Then on the another down in the South, Dr. Timothy Harlan has lifted the gold ring Center for Culinary Medicine, a slightly different approach than a lifestyle medicine maybe approach in terms of the nutritional content of that, but very successful, has been used in both resident and patient education, and he has a dedicated standalone kitchen as well. And then there's lots of other culinary medicine resources and training options. Dr. David Eisenberg from Harvard, in collaboration with the Culinary Institute of America in Napa, hosts a yearly conference, and it's a lovely conference, as you might imagine. And I went to that a few years ago. He has also spearheaded what's called the Teaching Kitchen Collaborative, which is people join that are doing culinary medicine so that there's a lot of cross-pollination and help with one another in terms of the successes and including the transition that we all had to make to virtual setting. There is a coaching certification, chef coaching certification called the Culinary Health Education Fundamentals that is led by Dr. Ronnie Pollack, and that is a collaboration between Harvard and the Institute of Lifestyle Medicine, and several people have gone through that. And then I went through the Ruby Culinary School, which has several opportunities. I did the 6-month professional certification, and it took me like a year to get through it all and document everything I'd done and take all my pictures to document things. But it was an amazing opportunity. They also have a 90-day Forks Over Knives curriculum and certification for professionals. And then recently they just have what's called a Switch online cooking community that's completely free. So this is a great resource for patients. And then they have a program called the Culinary RX that can be prescribed to patients. It's a 12-hour course on cooking techniques, on healthy cooking. So lots of opportunities with Ruby, which is a completely online culinary school. So provider education, as you know, is really the foundation of everything and everything that we do. And ACLM has been blessed with so many people coming into the organization that have the capacity to develop curriculum and are passionate about education. Lifestyle medicine education is now really gaining traction in undergraduate education. The University of South Carolina at Greenfield, I always say, is that Greenfield or Greenboro? I can't remember. But they have lifestyle medicine curriculum at all 4 levels of their medical school. But there's also, it's getting built out into residencies and fellowships and so forth. So the future is very bright in this becoming just part of medical education across the gamut. Wow, we got this pretty fancy. So for those of us that aren't going through medical school anymore and wondering how can we get more training, one of the many educational offerings through the ACLM is the board review course. The newest is the one that you see here, which is reversing type 2 diabetes and insulin resistance with lifestyle medicine. That's the one that I'm doing right now. And then there is a new course, physician and professional well-being as well. And then last, I just really want to, give your attention to this culinary medicine curriculum that is available free as a download. And this is the curriculum that Dr. Hauser developed on behalf of ACLM and basically deeded to ACLM. And it's been downloaded many thousands of times in many, many countries. And it can be really adapted to be used if you're in a teaching environment with residents, or whether you are in really want to be patient facing. And so it's an amazing resource, to help people get their traction and get started in culinary medicine. And that is all I have today. And boy, I sure hope I was able to stay within my time allotment and didn't disrupt anything in that way. So thank you for your attention. And again, I'm happy to send the references to any of you so that you can explore them.
Well, thank you, Dr. Collings. That was an amazing talk. Thank you for enlightening us and showing us how healthy eating and healthy eating practices and learning about this doesn't have to be bland. It can be delicious and very satisfying and exciting. I learned a lot from your talk, and I'm so grateful for the resources and training opportunities that you show us. I have a question about your own practice. What would you say is your main focus on that first visit when you're trying to engage your patient and get them? I guess there's different approaches, but what would you say is your main thrust that first visit?
That first visit. So really that first visit is very in kind with every first visit that you have, which is to really understand what is the patient's medical history, and to go into the weeds on that. And then, I usually have my patients do the Health Snap lifestyle assessment in advance. And so if I can, then we can kind of go into that and look at it as though it was lab data. I spend a bit of time really giving them the context of the lifestyle medicine review of systems, that we're going to talk about food each time. We're going to talk about exercise. We're going to talk about stress, and we're going to talk about sleep, so that they kind of come to, again, kind of see it in those terms. In that first visit, again, it is really setting expectations and, not oversetting expectations, and finding out their readiness to change. This is a big part of it, because we really don't want to be dragging people, because it just doesn't work. And so we really ask patients to look at their motivation and their confidence, that if under the best circumstances, what is their motivation and confidence? And sometimes when they're referred, they're kind of a little alarmed by that, because they want to be told what to do. And they assume they're going to be a little bit barked at, if not, just give me the information and I'm going to do it or not do it. And so, I play a little bit of like, let's see if this is the right time for you to make some substantive changes before we dive into it together. So that involves, a tool of readiness to change. I also actually have people go after that first visit, and it sounds a little woo-hooey, but I actually have them do a wellness kind of a vision. And it's amazing that does create traction, because they start to find out their why. They ended up in this office. They didn't decline the referral, or they came on their own free will. But if we really want to understand how we're going to work together to get that continuity and that change, then we need to be tuned in, and they need to be tuned in as to why do they want to put the work into it. And so between those things, it's very important to get those two pieces out of the way, and then really understand, are they here to reduce medications? Maybe they're not. Are they here because of symptoms, and they think that they'll get better just in terms of pain symptoms or other things? So, identifying what their needs are. Meanwhile, of course, I'm thinking what my needs are for them, but I really try to tune in to what their needs are. And that way we can get to it. And, sometimes patients find that they set their goal is to lose weight or something, and then they come back a month later and they say, that seemed so superficial. Actually, now I get it. Like, I feel so much better. This is working. I'm sleeping. All this stuff is coming together. And now I know the real reason I want to continue to do this. So it's an interesting time, but a lot of it's connection, Evelyn.
Yes, I hear what you're saying, and it is a very you need to engage your patient for sure in there. So I see my co-chair Nirali Vora here. Nirali, hi.
Hey, can you guys hear me? Thank you so much, Dr. Collins. I think this is just such an important topic, and I think it's one that a lot of us in our practice wish we were making more time for. I wanted to ask, you've really set yourself apart and started these programs kind of standing separately from the primary care, as I understand it. What is your kind of philosophy, or where do you think we should go and reintegrating it back into primary care or into, the primary cardiology or neurology, stroke neurology visit?
Right. That's a great question. And actually, when I began working on this, my vision was never to have it be a isolated consulting service. My vision was that this system that I was coming into was a growing primary care, mostly primary care, and that I wanted to see this embedded in just to the way medicine was done, a lifestyle first approach. And of course, you may or may not need to add medications, but to take that lens right away in the primary care physicians. It's not that yet, but we have one of our primary care physicians. We had two that were, kind of looking at building their panel through the lens of lifestyle medicine. But what happened is we also incorporated another whole group of physicians. So we were no longer building from the ground up in my mind. And so now it needed to be more of a consultative process, and in terms of sending patients to me to run these patients, if you will, in alignment with the physicians. But in the best of worlds, absolutely, I think it just needs to be how we practice medicine. I have a foundation grant, and we're training. I think we have 11 physicians that I reached out to get the foundation support for the board review course, and we meet every month. And out of that, we got even an ENT specialist. We got a palliative care specialist in that group. So we have quite a large variety of people that are interested in it that are not primary care physicians.
I have a question for you, Dr. Collings. Can you hear me?
Sure.
Two things come to mind. One is there's been a lot of attention on genetics and the human biome. And can you address possibly whether you're able to help people with rebuilding their biome?
Mm-hmm. Yeah. So, the predominance of a high fiber diet and a plant-based diet seems to be, the way that we can get the proper skew, if you will, towards a healthier microbiome. And so we don't do any microbiome testing. I'm not sure if it's ready for clinical use. And I sort of feel like it confounds or confuses what we know from the research is the right thing to do in terms of building a healthy microbiome. And then in terms of genetics, I had envisioned considering doing more genetic testing. Again, it's not always an easy thing to get clinically across the board in patients because of cost and so forth. But I really, the field looks at lifestyle working in epigenetic ways. And so again, the idea that yes, we have a DNA platform, but we have a software platform, our epigenome, which can trigger on and off DNA expression, and through some really fancy ways that I'm not capable of really describing, and nor should I. But I think the promise is that this is really how lifestyle works, is through epigenetic pathways, and that's why we see what we do. We have people with certain genetic propensities. Some develop the disease and others don't. So.
Thank you. And I see that we have quite a few of our leaders with us. And I'm wondering, Dr. Sky, Dr. Emmons, Dr. Marin, do you have any questions for Kate Collings? Of course, I can. Oh, here we have Ed Yu and Bill Baumer. Ed, go.
Thank you. Lovely talk. I really enjoy it, Dr. Collings. I wonder, could you speak a little bit about how well you tackle the adherence part to these lifestyle changes? As you know, it's difficult to break bad habits that have accumulated decades. And what's your approach on that, and anything you can help guide us in terms of making these changes permanent or long-standing for these patients? Thank you.
Yeah, there's there's no secret sauce in that, but I think there are some components that help with it. And I spoke to one of them, which is, people understanding their why, and connecting with a deeper sense of why they want to be healthy, and for who, or for themselves, or for what. I think that is part of what keeps people on track. Certainly the whip doesn't keep them on track. I think that, peer-to-peer support. So with our CHIP program, we have a CHIP alumni group, and they meet once a month, and they get another topic. And so they have this group of people that they can stay in touch with. We've also developed a Facebook group, and I know next to nothing about Facebook and don't plan to know anything about it, but the younger members of our team are delighted to offer this, because again, then that's an ongoing community for our patients, to do simple things like report successes or share recipes, and other things they've learned, and so forth. And so the peer-to-peer is really a lot of where the adherence can come from. Yeah, I think that's it. And then just really, I think the multiple touch points that patients have, and when they feel like they're part of a program, as opposed to just being, sent out to a nutritionist, but that they're on a course of care and they're in a journey of care. And I think the self-empowerment is one of the ways that people are best able to maintain adherence. And I'm sure we don't have 100% adherence, but I think those are all the components of that. And that's very unscientific, and that's very gestalt on my part, but I'm sure there's some data that tells you exactly what are the exact correlates of that adherence. But I think that's the common sense.
Thank you.
Just as a follow-up to Ed's question, this is Joe Sky. I'm a cardiologist at Travis Air Force Base.
Right.
Do you see the consultative role as time limited for your role, and then switching over to the patient support groups, or do you see it as a lifelong consult for the principles of lifestyle medicine?
Yeah, I don't. That's a work in progress, Joseph. I don't know if seeing me once a year will make a difference. I know it did in my cardiology patients, that, that connection kept that going. I think once people are off and running with this, they actually do feel more empowered. In fact, they're less, I think at some point, less committed to the physician. But I have some patients who say, no, I just want to check in. I like that accountability. And, a lot of what, I have a really deep respect for the whole health program within the VA. And has that been implemented with you? You're in the Air Force?
Yeah, it hasn't been. As you recall, we're working with Reagan's to implement some of your principles in the Air Force. But we've had pockets of experimentation and success throughout all of the Department of Defense, but there isn't a complete policy that covers everyone right now. Right.
Yeah, because I think there's just so much value that's come out of the whole health, and we have several people in the VA that, there's again some overlap in the concept of drawing in people's sense of meaning into the behavior change.
Thank you.
I see a name of someone I haven't seen for years, David Marin. Is that the David Marin that I knew at Stanford?
Very same, but my camera's not on, so I can't reciprocate.
Nice to see you.
Well, it's good to see you. And I didn't catch all of it, but I think I caught enough to have a good understanding, or beginning to understand what you're doing. I first of all congratulate you for getting this off the ground. I dreamt of doing something like this as I was graduating from medical school and couldn't figure out how to do it. And as you know, ultimately ended up practicing cardiology because I figured I could practice prevention on my own patients, which you pointed out, preventive medicine and lifestyle medicine are not the same, although I think there's a lot of overlap.
Correct. Mhm.
And I'm sure, so you have figured out a way to do this, and I'm sure that your patients benefit from it. But the real crux of my question is scalability.
Mhm.
I'm sure you would agree that lifestyle medicine should be taught in medical school.
Mhm.
Do you see it as becoming part of primary care, whether it's family medicine or internal medicine? Do you think that it would be more viable as its own specialty? Do you think that's even feasible? And just what do you see as the future for making a difference beyond just the patients that you see?
Right. Well, that's a great question. So I will answer that in three ways, so that I can remember it. I think that lifestyle medicine should be taught to, all medical students, so that they have that lens, and particularly embedded in family practice and internal medicine, the folks that are seeing patients, if you will, at the first beginning of conditions, so that they have an optimal place to impact patients. But I think there is also probably a need, and this is a little bit debatable amongst the people in lifestyle. There may be still a need for a super specialist, if you will, an intensivist, that basic information, so that if you're really trying to create disease, remission, that you may need people that are really just specialists that, in lifestyle medicine. So as a new-ish field that is coming, that, if you will, super specialist is coming, but it's not there yet. So I think it really needs to be a foundation, a blanket under all medical education, particularly in the primary care fields. But really where this is scalable, and I will be completely candid that, it's hard to keep these kinds of programs going in a fee-for-service, with a fee-for-service mentality. And where they really need to live is through the lens of value-based care or through the lens of population health. And because you can care for patients when self-care is the least expensive care that you can get. So that if you're in a model where there's shared savings or there's capitation, other things like that, that's where lifestyle medicine programs can really shine. Because there's presumably, once you get people going and into understanding the etiology and the root causes, well, then they're not going to see the doctor as often. They're not going to need as many pills. They're not going to need as many procedures. They're not going to be as much of a drain on that, amount of money that you are granted to take care of that patient. So lifestyle medicine in a fee-for-service model is marginally scalable over time. So it's waiting for more adoption. And in the areas, that's really the direction that the field needs to go.
Thank you. I totally agree. And it's good to see you.
Well, on that note, again, on behalf of the Right Care Initiative, really thank Dr. Collings for your time. Wonderful talk, and gives me hope that we can bring and leverage the concepts and bring it into the field of medicine in a more widespread fashion. So, Hattie, do I have permission to proceed?
Thank you all.
Of course. Yes, thank you, Dr. Yu, for helping to lead this next section.
All right. Well, it gives me extreme great pleasure on behalf of the Right Care Initiative to now welcome our next speaker. So next slide, please. So I have the distinct pleasure of introducing to you all Dr. Fujioka. He's an endocrinologist by training, and he has many accolades after his name. Currently, he is the director of Scripps Clinical Nutrition and Metabolic Research Center. He has special interest in the field of medical management, diabetes, and overweight people. In addition, he was the founder and the former director of the Center of Weight Management, which he started 20 years ago and now currently sees over 1,000 patients per month. In addition, in 1997, Dr. Fujioka authored a comprehensive standard of care program for the California State Medical Board on obesity treatment. With that, he has also authored over 100 papers in peer-reviewed journals and has served as a principal investigator for over 100 clinical trials. If that's not enough, he's also board certified in the American Board of Obesity Medicine, and he is currently the president-elect of the National Board of Physician Nutrition Specialists. So with that, I am extremely honored to have Ken to give us our next session. The floor is yours. Thank you very much.
All right. Hopefully you guys can hear me, and hopefully you can see the slides if I can ever get them to cooperate.
Yes, we do. Oh, by the way, the audience, I would welcome you to type your questions into the chat. So I'll be moderating it, and when Dr. Fujioka is done, I'll pipe in some questions. So please participate by putting questions in the chat. Thank you.
All right. Let's get back to the beginning. You can say I was practicing. All right. So let's talk about diabetes and obesity. So I'm going to basically define obesity and diabetes. I need you to understand both. Unfortunately, there's a lot of biochemistry here. Hang in there. It's not too hard. So obesity is essentially when somebody has enough excess fat that they're not going to live as long. They're going to get medical problems. We'll say a Caucasian male who weighs 235 pounds, normal life expectancy for that individual without the weight would be 74. It used to be 75, but with COVID, as you know, the life expectancy has dropped a year. So he'd be lived to be about 74 years of age. But the reality is at that weight, he would probably live to be 66, 67. So you're knocking off 8-10 years of life, but that's nothing compared to the quality of life, which is really going to be going downhill quickly. A lot of medical problems, and I don't have to tell you about all the medical problems. There's 197 of them related to weight. The other thing I want you to understand is obesity is a chronic disease. So whatever is the highest weight somebody gets to, the hypothalamus will now reset and permanently stay at that. It's a structural change. Will stay and want to stay at that weight for the rest of that person's life, no matter what they do. So it'll always be trying to get back, and I'll explain how it does that. I'll be darned if I can. I just want to see myself on here. Sorry, guys, I'm going to mess with this a little bit. For some reason, it's not showing. I need to see what I look like to make sure that I'm showing up okay.
You are. I can see you. And
Weird. You won't let me.
Slide says definitions of prediabetes and diabetes. Is that where you want to be?
No, I'm trying to put myself over there on the side so that it won't let me do it. That's weird. Okay. Oh, that's life. I'm trying to put myself over there so I can see what I'm looking like when I'm talking so that I can make sure I'm showing my points correctly. I know it sounds
Dr. Emmons is our in-house specialist, our IT specialist, in addition to being the medical director for SenCal Health. Dr. Emmons, if you're hearing, can you help out and unmute yourself?
Actually, I figured out a way to do it so I can kind of see me. So I'm good enough. Anyway, so okay. We have to define, sorry guys.
No problem.
I'm an old guy near the end of my career. I'm barely keeping up. Anyway, so normal blood sugar, less than 100 fasting, A1C 5.6, pre-diabetes, what I really want you to think about, a fasting between 100 and 125 or 5.7 and 6.4, and then diabetes is everything above that. Okay. So when you have somebody who's starting to get secondary complications from diabetes, does it start when they're a diabetic, or do you think it starts when they're pre-diabetic? What do you guys think?
Pre-diabetic.
Yeah, that's right. It starts in pre-diabetes. It doesn't start, all this is starting pre-diabetes. Pre-diabetes is really common, 1 in 3 Americans. I mean, when I do these studies, it's really easy to get patients. They thought I was some famous researcher because I did a study on these patients. I said, no, I just do an obesity study, and about half of them are pre-diabetics. So common relative to type 2. So the problems are starting earlier. The thing that I want you to understand, and I may not have some slides here to back this up because there's too much to teach. I don't have time, but if you can take somebody who's a pre-diabetic and switch them back to being a normal glycemic, guess what? You stop all that heart disease. You stop all the foot problems. You stop the renal disease. You stop it all, but particularly the cardiovascular disease. That's just a big deal because that's the big payday for insurance companies is, yeah, you end up in the hospital with a myocardial infarction. Yeah, it's expensive. Come on, keep going. There we go. So I'm also going to be very unpolitical, racial, whatever ethnic you want to call it. And obviously I have a personal interest because I'm part Asian. So the definition of obesity in the US is a BMI 30 or higher or BMI 25 or higher. Everything is set up that way, all the medical record charts, all that. But for an Asian, a BMI of 25 is obesity. And the reason why is that when you look at how Asians gain their weight, be it man or woman, they're going to gain it centrally. They're going to gain it right here. They're not going to gain it all over. Women, Caucasian women, African-American women who can gain the weight in their hips and thighs, they live forever. They do fine. That's peripheral fat. Peripheral fat, it's really easy to put fat into. It doesn't come out. It doesn't cause problems. But if you've got central weight gain, you're done. You're getting into medical problems real quick. You're going to get hypertension, diabetes, cancers, all kinds of really not good stuff. And so that's a BMI of 23 is even overweight. So again, it depends on how you gain your weight. And again, some Caucasians gain it only centrally. There are a few, not many Asians that will gain in hips and thighs, but relatively uncommon. And any individual has a BMI of 35 or higher, they got central weight gain. Sorry, you've just run out of places to put fat. And, you know, for those of you who are really into the research, essentially diabetes is where you run out of places to put fat and sugar, and you basically become a diabetic. All right, so just to give you an idea of how low these numbers are for Asians, and again, sorry, but, you know, I'm thinking this group is mainly Californians, and as you know, in California, the main group is Hispanic. The next fastest growing group is actually Asian now, and then Caucasians, African American. So that's for, say, a woman who's 5'4", she's Asian, that's a weight of 128. She's already considered obese. A male, 5'9". I wish I weighed 167. I don't, but that means I'm obese. Whereas that's opposed to 197, 170. So big differences here. This isn't all electronic medical records. If you look at the Hispanic population, we really don't know the numbers. We think it's actually closer to the Asian population than it is Caucasian. So it's probably, you know, instead of a BMI of 25, it might be 26 or 27. Mexico, they actually want to use 25, and they have very good data for it. They do very good work on this because, as you know, Mexico has surpassed the US in the percent of obesity in the population. BMI is in all electronic medical records. It's a vital sign. When I see a patient, the first thing that pops up is their blood pressure, their temperature, if I needed to get one, their pulse, and guess what? Their BMI, not their weight, their BMI. And pharmaceutical companies use BMI to determine who can get a weight loss drug. So it's a little bit unfair to Asians as a population. All right, enough of me on my Asian horse there. Sorry, guys. So central fat, the central fat, it's in your kidneys, it's in your liver, it's around your organs, it's in your heart. And it's not a very good fat organ. It's a fat cell, but when you put fat into it, it immediately is pumping out free fatty acids or fat into the blood. So now the blood has glucose and fat, and the cell doesn't care which one it runs off of. It can run off either one. Insulin doesn't care either. We keep the insulin, blood sugar. No, no, no. Insulin can push in sugar or fat. So what the body has to do is raise insulin in order to keep the person euglycemic or normal glycemic level. When you do that, though, now you have hyperinsulinemia. Insulin has its own problems, which we'll cover in a second, but a lot of insulin is not a good thing. And fat cells also release tons of inflammatory factors. The bigger the fat cell gets, the more inflammatory factors. So that's why we see more asthma as people get heavier. That's why we see more osteoarthritis of the hands, the knees, the feet, everywhere. Anything inflammatory. And then this combination of elevated insulin and then fat cells will make it estrogen. Women are getting breast cancer left and right due to the fat cells making insulin go high and making estrogen go high. Bad, bad combination. All right, so, and eventually the pancreas can't keep up. It says, look, I can't put out this level of 5 times the normal level of insulin to keep things up, so it starts to poop out. Guess what? You become a diabetic. So I was asked to just mention briefly about COVID because you probably have read, and it was brought up in the earlier lecture, that weight is, being overweight doesn't make you more susceptible, but what it does is it makes you more, you get a much more severe case of COVID. So as you get under the age of 60, what you see is this reverse curve where as patients get heavier, they end up in the hospital more because of COVID. And they end up more just getting admitted, more in the critical care unit. And we're not talking, 1.2, 1.3, we're talking 3 times more, 3 times more. It's a huge number. They end up on a ventilator, ECMO, you name it. All the, again, the pricey, bad stuff you don't want to get. Is this making sense to you guys, or am I way out of line?
Great.
Doing great.
Nope.
Thank you.
Sure.
We
Okay.
love it. Keep on
I'm
going.
kind of a crazy guy, I mean, I just
we love your energy.
Okay.
No one apologize for it.
All right, good. I don't know, All right. So what are your treatment options to lose weight? I mean, to treat this diabetes thing, really? Just lose weight, okay. Anything you can do to decrease the insulin needs is good. And so I'll push things like metformin. I'll give you other little tips of the trade. But remember, insulin is making things worse. One is insulin tells the body, because insulin says, well, I've got all this carbohydrates and fat coming in. I need to make more fat cells. So it's making more fat cells. Insulin is one of the best growth factors we know for 14 different cancers. 14. It's great for atherosclerosis. Insulin loves to shove plaques into the arteries. Insulin, I used to do these crazy studies when I was a much younger man, and I was willing to really do wild stuff, but I would literally infuse insulin to somebody while I'm infusing glucose. We call it glucose clamp. And you can just watch the blood pressure go up as the insulin goes up. So insulin is very good about raising blood pressure. And then anything you can do to decrease the inflammation is a good thing. Sorry, the only thing that lowers inflammation that we know of right now is weight loss. As many of you do know, though, COVID-19 is this nasty inflammatory virus. When it gets into your body, it just throws off this major inflammatory response. And the inflammatory response can be in the lungs, it can be in the heart, it can be anywhere. So the combination of an overweight patient who already has inflammation and all the factors ready to go, and then the virus, hence you see why these patients are ending up in the ICU. 5 or 10% weight loss is enough to lower this inflammation dramatically. All right. So now
Ken, I just have to say, you're the first person to help us understand why patients are absolutely paranoid to go on insulin. Your last slide showed us why they have reason to fear.
Oh, it's a whole nother talk, but yeah, once you start somebody on insulin, you basically giving them a death sentence. They're going to get cardiovascular disease. They're going to get strokes. They're going to get all kinds of bad stuff. But yeah, it is what it is, because sometimes that patients will get to a point where that's all you can do and you got to do it. And I'm an endocrinologist and that's my job, but I'll avoid it as long as I can. All right. So the goal, in a patient who has diabetes and obesity is to improve their A1C and improve the comorbid problems, the hypertension, the renal damage, or kidney damage, the nephropathy, the cardiovascular risk. You want to lower all that. And you want to improve their quality of life. Now, this conflicts with what the patient wants. You know what the patient wants? They want one thing, weight loss. That's what they want. They want weight. They want to lose. I have so many patients that could care less about the other stuff. So what if there's protein in my urine? I don't care. So just get me thin, get my weight down. Because I tell you, life is tough on the overweight patient. And again, that's another interesting talk. So as a doctor, and Haiti showed you data earlier showing that San Diego did particularly well in meeting the metrics of diabetes care. And I'll tell you how we did it. And it's brutal on the docs, and some of the docs had to really, tighten it up because we didn't get paid if we didn't get the metrics met. So the metrics were, you had to get 2 A1Cs, with the most recent one being less than 8. You had to get a blood pressure, 140 or 90, better than that. You had to get an LDL less than 100. You had to deal with, if they had proteinuria, you had to deal with it and you had to check it. And if you didn't get all 4 of these things, all 4, you didn't get paid. Can you imagine that? I couldn't pay for my kids' college. I said, look, sorry, man, you got to go get a loan, man. Okay, so weight loss is the only thing that improves all these metrics. And I got a great paper coming out where I actually show the doctors that do weight loss, because they're boarded in obesity medicine and endocrinology, had better weight loss than the endocrinologists who didn't. Why? Because they treat the weight. All right, so how much weight loss do you need? Not huge. You get, can you guys see my cursor?
Yes.
Okay, good. So you get as little as 2% weight loss, 2%. If you weigh 200 pounds, that's 4 pounds. You're already getting a better A1C. You get 5 to 10%. Oh, look at that drop. That's as good as any drug. You get 10 to 15. Now you're better than drugs. And folks, this is where at the end of this talk, you're going to see how everyone's going to be at this number in a year. Medicine is changing. Scary. Blood pressure, as you get heavier, your systolic goes up. So as you lose weight, you can see the systolic gets a lot better. I mean, dramatic. Again, this is better than any blood pressure med I know of, unless you give massive doses. Diastolic comes down none. If they had bad diastolic blood pressure, okay, break out the drugs big time. Now, this is where I'm going to deviate. Weight loss isn't the cure for everything, just about everything, but not quite. So you can see this triglycerides coming down just dramatically. I mean, these are huge drops. We have, nothing that does this. HDL goes up. Your protect cholesterol goes way up. I mean, these are, because HDL is such a small number to begin with. That's a huge increase. But look at LDL. It kind of goes up because you're lowering triglycerides. LDL is going to go up. Then it kind of figures it out and levels off. So it doesn't really change. Now, the LDL particle becomes big and fluffy or less atherogenic, but the LDL will not improve. So when I'm teaching all the docs in my institution, we've got a couple of thousand docs at Scripps, I tell them, look, if you really need to get the LDL down, get them on a statin. Weight loss is not going to do it. Or in other words, you won't meet your metric. Everything else will with weight loss, but not the LDL. And LDLs, they're generic, they're cheap. All right, so what are your treatment options to lose weight? 5 to 10%, that's all you really need. There's diet, exercise, and then we just had an expert talk on lifestyle modification. There's diet, exercise, and lifestyle modification and weight loss medications, and there's bariatric surgery. Basically, most programs do either the sleeve or the bypass. Everything else, you really don't want to waste your time on. And you can see my name associated, having studied a bunch of these different things. These are the 2 that work. So anyone want to guess which of the above is going to give you, what percentage, if you do diet and exercise lifestyle, what percentage would get 7 to 10% weight loss? Anyone want to guess? How about with meds? How about surgery? So diet and lifestyle, about 20% can suck it up and do it. They're going to bust butt. These are going to be folks that don't have quite as much to lose. They're going to be OCD assessment, no, but they're going to be really on track. They're going to record their food intake. They're going to exercise. They're going to do everything you tell them. And I'm always amazed because I always think, oh, I can tell the patient who can do it with lifestyle. I can't. And I've been doing this for a long time, and I'm really good at telling when people are lying. I'm so good at that. It's ridiculous. Patients are scared to death of me. So you can't tell. You try it and see. That's the only way you can do it. Lifestyle with weight loss medicine and actually this number is going to go up to 85% by the end of the year. That the new meds coming out are that good. And then surgery, yeah, 85%. They're going to do it. Surgery is by far the best thing for the overweight diabetic. All right, so what do the guidelines say about how do you lose weight? And there's two things you need to know, but one take home. Find the diet that works for that patient. It doesn't matter if they want to do keto, if they want to do intermittent fasting, if they want to do the Fujioka full moon diet, it doesn't matter. They can do any of those as long as they're going to work. So what you do is you want to get them in a calorie deficit, women 12 to 1500, and I like these programs. Jenny Craig, Weight Watchers, these are proven programs. I wrote a chapter of a book where I went to all these different programs. I had a fat suit on. I was a patient in every single one of these and wrote about my experience. I became famous on YouTube channels. Subscribe if you like this. Anyway, and no, just kidding. I'm not on YouTube. But they put almost all the women on 12 to 1300 calories because it works one way or the other. Men, 15 to 1800, it works. Or 500 to 750 deficit diet. Or prescribe one of the evidence-based diets that say restrict certain foods, like you can't eat any high carbohydrate foods, or you can't eat any low fiber. It has to be real high fiber. I once did a diet that you had to eat 100 grams of fiber per day. You could eat anything you want as long as you ate 100 grams of fiber per day. I lost weight and I moved my bowel 6 times a day, but it was great. But it really does work. But again, find what's going to work for that patient, or eliminate high fat foods, whatever. But do something that you think the patient can do and then go from there. And these are guidelines. These are old guidelines. The guidelines that come out by various other groups say the same thing. All right, this is a typical patient I will see. A 50-year, so San Diego, as you know, we got a ton of like engineers, bioengineers. We're not quite like San Francisco and that much biotech, but we got a lot. But we have tons of wireless technology here. I mean, you got, you name it, Qualcomm, so forth, Ericsson. Anyway, so your patient comes in, he has his iPad ready to show me with all this data. He's done Dr. Google a million times in his sleep. And he does realize that he's an overweight, newly onset diabetes. He's got to lose weight. So he's done one of these saliva tests, where you spit into a tube so that they can get enough of your buccal mucosa to do his genetic testing. And he doesn't care if they own his genetics now for the rest of his life. And if all his, kids that he had before are going to find him, he just wants to know what is the perfect diet for him. And so the genetic tests say the best diet for you is a low fat diet. But he said, I don't want to do that. My friends are all doing the keto diet. They go to the bar, they do shots of tequila and they eat burgers without the buns. It's the best life. I got to do that. So what do you tell them? Do you tell them, no, you should really do the low fat because the genetics say that? What should you do? Anyone want to guess? Would you say, yes, do it, or no, you can do the keto if you think you can really do it and you lose weight?
Do the keto.
Okay, there we go. It's more fun anyway. So, and I wish we would have had our other speaker on because she probably knows this guy, Dr. Gardner's up at Stanford. And this is not the first study of its kind. I just picked it because it's the most recent. But he took 609 people. This is a big study, expensive study. He got a huge NIH grant to do this. 1 year long. I love it because don't do weight loss studies. These 3-month studies, they're okay, but you really want at least 6 months, 12 months is better. And he randomized them to a low fat diet or a high or a low carb diet. And I'll tell you what those are in a second. And he also did genetic analysis to find out who was the low fat genetic type and who was the low carb genetic type, 40% and 30%. And again, we talked about how common pre-diabetes is, and you can see that the average blood sugar was 98.4. Normal is 99 or less. So that means almost half were probably pre-diabetics. A third had metabolic syndrome. Oh, and then he also did a 75 gram glucose challenge to see who was making too much insulin. So who was insulin resistant, which I like. I do a similar test in practice. Okay, so the diet was essentially a low carb. Anything less than 100 grams per day of a low carb diet will work. If you want to go to ketosis, as a scientist, I'll tell you it's 50 grams or less. All the keto diets say, no, it's got to be less than 20 per day. And the reason why is if you tell a patient to eat 100 grams of something, will they overestimate their intake or underestimate their intake? Come on.
Over.
That's right. By 35 to 40%. So that's why they use that 20, because they want to make sure they really do get into keto, which I tell you, 20 grams is really hard to do. Anyway, so just, in general, when I'm teaching docs, say, look, if you want to do low carb, just do less than 100, round number, easy to do. If you want to do a low fat, then you want to go under 30% fat, and your carbohydrate will probably be over 200. That's okay, it works. But this is what he found, which, kind of surprised some people, is that it didn't matter which diet. So the healthy low fat diet, they lost 5.3. The low carb diet lost about 6.0. My guess is the weight loss in fat was the same. When you do a low carb diet, you get a little bit of a diuretic effect. So you lose a little bit of water. As soon as you eat the carbs, the water comes back. But to make a long story short, the people who had the genetics for the low fat diet didn't lose any more fat, any more weight on the low fat diet. And the patients who had the low carb diet didn't lose any more weight, even if they had the low carb genetics. He found the same thing, although this was close. When I looked at it, I might have called it differently, but if you read the paper, he comes out and he says that, in essence, high insulin secretors or insulin resistant folks did not lose weight on the low carb diet, which you would have expected. And the low insulin did not lose on low fat. But it actually, there is a study that refutes that. And if you look at his data carefully, I think it's a little bit there. But I mean, insulin studies are not easy to do. We do these not in private practice. So it's not something I say, do this at home. If you have a guy like me who does them, sure, find him, pay the big bucks. Scripps takes any insurance. So don't
Just slow down a little bit on the high insulin secretors, the low insulin secretors. So does that mean something about central adiposity? Can you just help us out a little bit here?
So more than likely, your central adiposity folks are going to be producing way too much insulin. And when they do, so the best way to get the insulin down is just lower the carbs. If you take away carbs, the body is forced to lower insulin. So that's in theory why high insulin secretors or central obese patients may do better with a low carb diet. And again, this is a debated point. The top thing, though, I would strongly agree, the genetics, they're worthless right now. They're not ready for prime time. Someday they might, but they're not right now. Okay, but you know what? I'm not into low carb diet. You know what I'm into? Fasting, intermittent fasting, time restricted eating. That's what all the patients come in. He says, yeah, I got to do this alternate day fasting. Alternate day fasting, I'm not going to spend much time on because it's tricky. It's fascinating. And the science behind it is drop dead gorgeous. It's really good. And if you want to read a good review article, New England Journal last year had a really good review article on it. But to make a long story short, you eat 25% of your calories, or about 500 calories per day, every other day. So you're forcing the body to just tear into its own system to get calories, be it both protein and fat and your glycogen. The good and the bad of that is that the theory is that when you get so low that you actually take away your bad cells that you don't need. Theory. Now, time restricted is what most of my patients like to do. They usually like to eat between 12 and 8. Some of my hardcores will be between 4 and 8. So they're really restricting 20, 16, 8. You can look, again, you can PubMed, and I maybe see, I just did a study showing you can actually do it from 10 to 8 and you'll still get some weight loss. That's more than expected. But that's what most of them doing. The best way of doing this, but most of my patients don't like to do it, and again, a whole nother talk, is to eat only between 7 a.m. and 3 p.m. and then fast the rest of the time. Metabolically, that's the best. But at the end of 3 months, it's 3 more pounds. I don't care because I know I'm going to get 15, 20 pound weight loss with 12 to 8. I'll take it because patients can do it. They want to eat with the family. They want to be human beings. And again, that's what you get when you get a weirdo like me who does research, but also sees patients. I'm going to tell you what I see in the research side, but what really happens in the doctor's office. So the first question is then, can you skip breakfast? And I was taught when I was doing like my hardcore research in the 90s that breakfast is the most important meal of the day. You have to have it. You're breaking fast. But those are just observational studies. They're worthless. If you look at the truly good randomized controlled trials, guess what? They show something very different. And I'll show you the data in a second. So typical American breakfast, milk, toast, and OJ. But what they found, and the big knock is that if you skip breakfast, then you're going to overeat at lunch and you're going to overeat at dinner. Well, guess what? You don't. Here's the group. They ate breakfast and they ate lunch. This is about 400 calories. This is about 1,000 calories. At lunch, they ate about 1,100 calories. Okay, 100 calories more. But by the end, and dinner was exactly the same between both groups. So to make a long story short, the calorie count at the end of the day is lower if you skip breakfast. Now, you have to truly not eat any calories. And I'll explain this in a second, why that is. So they can't have coffee with cream and sugar, or they can't have one of these protein bars that are keto friendly. You really have to fast because you're going to force the body into a form of ketosis. When they looked at their appetite scores, this is the appetite score. It is higher for the fasting group in the morning, but as soon as they eat, because they eat, their fasting score, their appetite scores come down, they catch up. So it's not surprising that they don't eat more later on because they're the same. Amazing. And there's another study that I can talk about that actually we measure the hormones that control appetite, and they also don't shift for whatever reason. So again, this is, you got to study. There's no single area with more misinformation than obesity medicine, and in particular diets. It's just, that's the way it is. Anyway, and I've been like the dirge of every doctor's said, Ken, why are you going into weight loss medicine? What's wrong with you? You know, and you got into, you could have done anything. I go, because I like it. Also, I did it to keep my own weight down. But anyway, all right. So
needs you, Ken, right?
Pardon?
Because everybody needs you.
That's,
I've
had a job forever.
So when I used to not eat breakfast, which was before I was married, I only had coffee with skim milk in the morning.
Perfect.
Well, I was thinner without breakfast.
Okay. All right. So in this study, skipping breakfast does not alter the size of the meal later in the day. We're going to talk about energy expenditure in a second. Subjects that report hunger later in the day, it's the same. It's not any worse. And they end up eating, in this study, almost 450 calories less. Oh, you got to love that. Now, this is a more technical study. Japanese are very good. This is done in Japan. They're very good at having what I call gadgets, really cool gadgets that measure activity, accelerometers, all kinds of things. It's not just step counts. I mean, you name it, they can measure it. So they really know exactly how many calories somebody's burning. And they took a group of 20 healthy Japanese women who normally ate breakfast. And Japanese women by nature are relatively small. They're going to be about 5 foot tall. They're going to weigh about 100 pounds. I mean, these are tiny women. So the numbers will look small. They're significant. So they did find if they skipped breakfast that they ate about 131 more calories at lunch. But if they went to the end of the day, once they ate lunch, they were a negative 262, which is a big difference, again, for a small woman. So in essence, they ended up eating less calories. Now, their step count was the same. Their physical activity was the same at the end of the day. But if you did look just in the morning, there was, which is to me nothing. This was numerically different, not statistically different. 41 kcal difference in the activity level, because then they're measuring everything, which is to me very impressive. Why? How does this work? So typically we're getting calories throughout the day, breakfast, lunch, and dinner. We're making lipids, we're storing fat. But if you fast, as soon as you get to even 12 hours, 14 hours for sure, up to 36 hours, you switch over into what we call free fatty acid metabolism. You've used up your glycogen, you have no more carbohydrates to use, you have to go after the fat and pull fat out and burn it. And when you do that, you get a leftover product, ketones, because ketones can be used as energy. And you need that for the brain because the brain cannot run off of fat. It can only run off glucose and ketones. That's why when people do a keto diet, they just feel so cool because their brain's running on ketones, which is a different feeling. Rats like it, but they're used to running on that. They do better in mazes. I've never seen a study in humans where they think better. But then again, we don't think any better anyway. All right. So So what's the big advantage? Why is everybody pushing this? So once you get into this, you burn up your glycogen and you're burning your fat, it seems like you protect your lean tissue. Why is that a big deal? Because when you lose 4 pounds of fat, of weight, you don't lose 4 pounds of fat. You lose 3 pounds of lean tissue, 3 pounds of fat tissue and 1 pound of lean tissue. Older adults, my group, 65 and older, geriatrics, it gets scary. We lose maybe 2 pounds of fat and 2 pounds of lean tissue. Not good. So in essence, this is something I like to do in my older patients. But again, this is all new science, new frontier, amazing stuff. All right. Did I got your attention, guys? No. All right. Maybe this will get your attention. So using exercise alone to produce weight loss is not as fruitful as you'd like it to be. You know, typically 0 to 3, 0 to 1, 0 to 3%. Clearly, aerobic and resistance training is the best. This really should be more like 2 to 3%. But if you combine calorie restriction with any kind of exercise, but particularly aerobic and resistance training, 5 to 15% weight loss, much, much more. How much time? It's a lot. The current recommendations are 150 minutes per week. Anything less, you can see you really are not going to get weight loss. And great studies to show this. 150 to 25, okay, now you can get some weight loss, 2 to 3 kilos. And again, I don't want to pick on women, but women have much slower metabolic rates. They don't have testosterone. So their ability to burn calories is lower. It's just a mathematical equation. And so they're going to be closer to this end, which is a lot. You take a postmenopausal female and you're telling her she's got to exercise 400 minutes per week. She may not like you, but that's what it takes. Guys, we can get by with about, 225, 300, again, because we have testosterone, we have more muscle mass, we got more metabolics. But again, maintenance, you're looking at big numbers. All right, medications. Actually, am I running out of time? Am I doing okay or what?
Yes,
I can
you're doing
forego the
well.
medication if you want.
Keep going. You're keeping us entertained.
Okay.
Yes, please.
Well, it's probably cocktail hour for a lot, so go ahead and feel free to grab a beer right now or a wine. Okay.
Those are carbs.
Yeah, actually, okay. So this is an interesting thing. So how many carbs do you think there are in a glass of wine? Red or white, doesn't matter.
No idea.
Okay, good. Because I didn't either. I thought, oh yeah, there must be 10, 20, 30, 2 or 3. It's a low carb drink. Beer's the same way. If you get like to the high end stouts and your porters, they actually have like 12, 13, 14 grams of carbs. But your standard pale ales, your pills, your standard beer that most Americans drink, it's 2 to 4 grams. The low carb ones are 2 or 1. The diet beers, I call them. But anyway, so they're all really low carb. It's kind of funny. Anyway, and we all fight when again, I'm not a lifestyle guy, but I do tons of research on different diets. And when we do research on alcohol, we fight over the answer of whether alcohol really causes weight gain or not, because alcohol is really hard. Alcohol is a calorie, but it's hard to turn into fat. We don't have the biochemistry for it. So what happens is, though, it disinhibits or dysregulates our eating. So we eat everything in sight. So it's more of a, it's not good for your eating behavior. Anyway, well, okay, let's talk about a magic pill. So we have a magic pill that came out a few years ago called an Sglt2 inhibitor. It'll get you to pee off about 100 grams of sugar in the urine. That's 300 calories a day. So theoretically, if you put somebody on this, they should just keep losing weight, right? They're losing 300 calories every day. They don't even need a diet. It's like the perfect drug, right? That's not what happens. What we see is this. If you give somebody an Sglt2 inhibitor, they'll lose down to about 3% and it'll flatten out. It'll even come up a little bit. So in essence, they lose about 2 to 3%. And believe me, this trial's been done multiple times because they find the same answer. They can't believe it. Because as you know, or may know, we've done a ton of studies on Sglt2 inhibitors as weight loss agents, and it's always failed unless you combine it with a weight loss drug. Why? Because of this. You see this change in food intake. I mean, it's very abrupt. Within 8 weeks, you've ramped up your calorie intake 300, 400 calories a day to match this so you don't keep losing. This is all being done up in the hypothalamus. How does it do it? So when I first started in the field of obesity in the 90s, I really thought that you saw food, you smelled it, it was time to eat, so you released all these hormones that drove you to eat. Turns out we only know one hormone that does that. It's the other way around. Every one of you there, all your patients are wired to eat 24/7. Your brain says, feed me, feed me, feed me. And when we eat a meal, we send, look at all these hormones, and there's more to tell us to stop eating. So it's a system that's turned on all the time, but then in essence, we'll release, this is a ton of hormones that go up, they get up into the hypothalamus and tell us to stop eating. NPY is the bad guy, POMC is the good guy. Now, the one we know the best is GLP-1. Why? Because it started off as a diabetic drug, which I'll cover in a second. But to make a long story short, it goes up into the brain and turns on POMC and tells us to stop eating. It turns on the vagus to tell us to stop eating. It even tries to go to the reward system. We do have a system that we can override all this. So you've eaten this, nice, you've gone to your favorite restaurant. You just had a great meal. And you're full. You don't need to eat anymore. But the waiter walks by with this dessert tray and it has your favorite dessert on it. Do you want to eat? Of course you do, because you want that dopamine, norepinephrine rush because they have that favorite dessert there. So that has nothing to do with appetite. That has to do with reward eating, which a lot of people struggle with. All right, but this is the study that just flipped everybody's mind to, obesity is a chronic disease. There's some permanent change in the hypothalamus. And Sumitran showed this in 2011. He got patients to lose 30 pounds on a 10-week weight loss program. They regained 10 pounds. So they were down about 20 pounds or 10%. And what he found at the end of that, now PYY is the most potent satiety hormone I know of. I've worked with this hormone numerous different ways, and it's so good at telling you to stop eating. You feel nauseated and throw up. That's how potent this thing is. Eventually they'll get it wired, but I'm near the end of my research days, so I'm trying to call it quits. But look here, this is their level when they eat a meal. Look how high it is before they start. This is baseline. Now that they've lost 10% of their weight, it's lower. It doesn't come up to the full level. As a matter of fact, that's about 2/3 its normal level, telling you that the hypothalamus is reset and won't send up the satiety hormones, all the satiety hormones, GLP-1, PYY, GLP-2, CCK, all the same. Ghrelin, the only hormone we know that makes you want to eat more, guess what? It's higher, trying to make you eat more at the end of the study. So telling us this is a permanent change. So your food, you're driven to eat more, and you don't get full as much when you're at a lower weight. Here's the other scary part, your metabolism. This is due probably to the hormone leptin, which comes from your fat cells, not the gut. But your brain needs to know how much fat is around in order to survive, because we died of starvation 30,000 years ago, which is about how old our own personal genetics are. I mean, we could have had babies with anybody 30,000 years ago. There was no difference in our genetics. But you get between a 15, and that's total energy expenditure, not resting energy expenditure, 15 to 30 kcals for every 2.2 pounds or kilo you lose. You drop your metabolic rate by about 15 to 30 calories. So if you have somebody who's lost 20 pounds and is now 200 pounds, they need fewer calories than somebody who was always 200 pounds. Does that make sense, guys? This is a hard concept.
Yeah.
Okay, good.
Hard. That's hard to really believe if you're exercising a lot, because you'd think that would boost your metabolism, but please continue.
That's right. No, and that's the tough part. Exercise does not increase your metabolic rate. It'll help you burn more calories, and intensity matters. And that's why particularly older patients have to lift weights and do cardio. But the fact is you can't increase your metabolic rate only with hormones, because the body will lower it purposely. It does that because it wants the weight back. It wants to be back to 220.
What did you
And
say about needing to do cardio and weightlifting about metabolism? What was that?
so you can blunt some of this by lifting weights, but just blunt it. You don't, it's going to be closer to that 15 instead of 30, but you can't stop it. Does that make sense?
Yeah, yeah.
Okay, good. And if you ever want to look up the study, it is a great read. I know way too much about The Biggest Loser because I'm in San Diego. A lot of them live in LA. They come down to my office, and so I meet them, the professional weight loss losers, and they have to go to the best. But they just know that I use weight loss drugs, so that's why they want to come to me. Anyway, they followed them for 6 years. And guess what? At the end of 6 years, their metabolic rates, now these are big folks, bigger weight losses, 100 pound weight loss. The metabolic rate was depressed 750 calories per day, 750 calories per day. Oh man. So long story short, for every kilo you lose, you increase your desire to eat by 100 kcals per kilo, and roughly 30 kcals for every pound you lose, you drop. Permanent. This is why obesity is a chronic disease. All right, what kind of drugs do I like to use in the diabetic who's obese? Metformin, Sglt2 inhibitors, a GLP-1. Why? Because I want cardioprotective effects. I want to improve their microvascular complications. All right, so metformin, cheap, generic, very safe. I mean, incredibly safe, other than nausea. And there is a group that won't tolerate it. And if they can only tolerate 500 milligrams a day instead of 2,000, give it to them. The best dose is 1,500 milligrams per day or higher. But again, 500 will work if that's all they can tolerate. And the interesting thing is that this is truly a metabolic effect. You can measure their food intake. The study's been done, gorgeous study, showing that even though the food intake didn't change, they still lost 2% of their weight. That's fascinating. And it stays up. It doesn't creep up like SGLT2 inhibitors. It improves insulin sensitivity. You're lowering insulin. Good. Great. Phenomenal long-term experience. It's inexpensive. And even if a patient is on insulin, you can lower their needs by almost 30%. All right, good drug. SGLT2 inhibitors, again, I love it. 300 calories negative, goes into the toilet bowl, 2 to 3% weight loss. But if you add an appetite suppressant or you add a GLP-1 at lower food intake, you're going to get great weight loss. We're talking 10, 15%, really good. One group I worry about, diabetics on insulin, probably shouldn't use it. Reason being is that when you're excreting glucose in the urine, you actually lower your ability to excrete ketones so they can get ketotic. And they even have fairly normal looking blood sugars, yet they can go into ketoacidosis. Not a good thing. But all the other diabetics, oral meds, all that kind of stuff, go for it. Be fine. Good. The SGLT2 inhibitors all have improved cardiovascular outcomes, lower risk of death of any cause. Why? Even if you get 2 to 3% weight loss in the long run, great. Lower risk of hospitalization, protection against end-stage renal disease. Not complete, but you lower the risk. For every patient you keep off of hemodialysis, oh, that's a win. Now, the GLP-1s, though, this is the future. This is what everything is going to copy this that you're going to see coming out. And by the end of this year, you're going to see a GLP-1 that's going to come out that's going to blow everybody's mind because it's going to give you weight loss that's going to be equivalent to, you got it, or close to, not equivalent, but close to bariatric surgery. So first off, beautiful study showing that GLP-1 has receptors in the brain to tell you to stop eating. Good. It also goes to your alpha cells, tells you not to make glucagon so you don't raise blood sugar. It also goes to the liver, helps out glucagon and helps out possibly with some of the fat deposits there. More importantly, it slows gastric emptying. And that's why the nausea with all the GLP-1s, you get nausea in the beginning. So you may have to use a very low dose. But the nausea is because you can't empty your stomach. And patients will tell you, yeah, if I overeat, I'm really nauseated. So it forces them to eat a smaller meal. I can really, we're running out of time. I won't go over to L cells because they're the fascinating cell that's going to just blow everybody's mind in a year. Anyway, so GLP-1s, cardioprotective. In other words, when they do these cardiovascular outcome trials, you take between 5 and 15,000 patients. These are basically $500 million studies in which they have heart disease, they have diabetes, they're ready to have a major event. And you randomize them to either placebo or one of these, and they all showed that it was better than taking the placebo. They had less cardiac events. They lived longer. They did great. You improve insulin resistance. You get weight loss. You get decreased blood pressure. You improve dyslipidemia. Now, not all the GLP-1s are the same because they originally were all coming out for diabetes, but you can see semaglutide is top dog, liraglutides and exenatide are pretty high up there. Dulaglutide. Now, dulaglutide now has, because they realized more is better, so they have a bigger dose. They have a 3.0 and a 4.5 milligrams. So this will probably start to get way up here. So good. But with semaglutide, again, the more you give, the better. And this is just their data showing that, again, when you look at the rate of death, you're looking at cardiovascular events at the end of this study was 54 months, 8.2 versus 9.6 in the placebo. That's statistically significant. They never thought they would show that. They just thought they just wanted to show they were safe because that's all the FDA wants. They showed superiority. Bariatric surgery, hey, if you got a patient with a BMI of 35 or higher and they have type 2 diabetes on insulin, this is your best bet by far. So he took group patients where they did intensive diet. Now, they didn't have much in the way of GLP-1s and SGLT2s when they were doing the study. They kind of came into the end of the study. But in essence, you can see that their goal was to get their A1Cs down. Well, bypass did it great, 7.3%, 7.4. Here's the med group. So yeah, surgery went out. Weight loss, 5.7 in the drug group, 22% in the bypass, and 18.5. Why am I telling you how much weight loss? Because we just want to know their diabetes, their numbers get better because of this. This is the most recent study to come out in semaglutide, which should be out within the next 12 months. Look at this weight loss. So everybody gets semaglutide here. So for 20 months, everybody gets the drug. Here, these poor group got placebo. Guess what? Because we know they don't make it, their body's losing weight, it's fighting weight loss, it doesn't like this. And now you've stopped your GLP-1, their GLP-1 is really low now. They start gaining weight. But look at this group, 18% weight loss. Hey, wait a minute. The sleeve group got 18%. Oh my gosh. Amazing. The future is going to be all these physiologic hormones. It's not going to be stimulants. It's not going to be anything else. You're going to see these PYY, leptin, GLP-1 combos all linked into one hormone. We know. So in the past, it's been really hard to be able to, we have always had the ability to link amino acids together to make a hormone. But what we haven't had is folding it the right way. It's really tricky. They now have that down pat for all these hormones. So they can copy every single one. They put them into a single hybrid molecule. You inject it once a week. You're going to see weight loss easily as good as bariatric surgery. And these things are going to be unbelievably safe. Why? Because they're hormones. So you're not going to get what we call off-target effects. And I made it to the end, guys. Whatever you want to talk about now. But I know you guys, it's cocktail hour, so you guys want to go have a drink.
Well,
we invite people
wonderful.
to have a glass of wine with the discussion section if they would like to do that. Dr. Yu, you're on.
Well, thank you, Ken. Thank you very much for this talk. A very entertaining presentation. I love your passion.
Everybody, come on now, Ed.
Well, there's plenty of questions that came in, and some of them were really passionate about some of the points you made. So the first question was someone that kind of want to challenge you about your comments about insulin. So the question is, how do you expect to get euglycemia in a patient with weight loss due to insulinopenia related to glucose toxicity?
Okay.
So that's
I'll completely agree. You're right. If somebody is just, their pancreas is done, they cannot make enough insulin, then it's going to be extremely difficult without insulin to get their blood sugar down. So you're exactly right. Hence, what I didn't mention, I don't know if you know this, there's very good data that the GLP-1s, as we know there's receptors on the beta cells that make insulin for GLP-1s to tell them to make insulin. What you may not know is that these same GLP-1 receptors will also tell the beta cells to make more beta cells. And that's very well shown in animals, and there's no reason to believe it won't happen in humans. So, but you're right. Patients that are truly insulin-penic, yeah, I got to give them insulin. Sorry, that's it. I try and give them as little as I can. Patients that require, say 10, 20 units of insulin, okay, more than likely, I'm going to get them off insulin with weight loss and a GLP-1. But again, I bow to you. You're right. You got to give insulin.
All right, thank you. I'm sure they'll feel better now. Another question here. What are the potential harms of intermittent fasting in a patient who's diabetic? Is it safe for diabetics?
Okay, good. Very fair question. So the keto diets is where we worry more because you're getting into ketosis by simply eliminating carbohydrates. Intermittent fasting is different because you actually are just intermittently fasting. In other words, you're getting into ketosis because you're just not getting calories at all, zero. So you're forced to use up your glycogen. So quite honestly, they can't find any problems right now. The only group that they can find problems in is the group that we just talked about. It's the diabetic on big doses of insulin. If they're on low doses of insulin, you can do it. But if they're on big doses of insulin, you do run the risk of putting them then into actually ketosis. It's a weird euglycemic ketosis, not your typical ketoacidosis, but it's an odd one. But that's the only risk I know of. So if somebody is on big dose of insulin, yeah, I would stay away from intermittent fasting. If they're on low dose of insulin or just on orals or GLP-1s, you're fine. We just can, and believe me, people have tried, because there are a lot of people that really, again, I like your word, Ed, passionate, but they're very passionate saying, oh no, that's the worst thing you can do. You got to eat breakfast, all that. But again, the data is just not backing them up.
Good, thank you. Here's a question about BMI, and this is someone that wants to ask a question. What happens if you're not obese? So if you're not obese, are there still health benefits from weight loss? Is there a goal for healthy BMI? Is lower the better?
Okay, to a point. So depends on actually your age too. So for whatever reason, in the geriatric crowd, age 65 and up, it is not good to go below a normal BMI. So you don't want to go below 20. For whatever reason, you don't live as long. And unfortunately, that's a sticky study, because you worry about some early cancer or something like that, making that look odd. But to make a long story short, don't go under a BMI of 20 for that reason. Under, we'll say 55, 60, you want to be at the lower end. I don't know of any advantage to being below that. Now, with that said, there are very good studies about this, as you know, this kind of chronic calorie restrictive diets where you're always under eating by about 15% to improve your longevity. And there is data that works. But again, if you get too thin and you get COVID or you get anything, you're done. I mean, you have no reserve. So a lot of, I would go to this New England Journal of Medicine article. I can't remember the name of it, but it's a review on intermittent fasting. It was written last year. And they go over all the merits of intermittent fasting in a normal BMI group. And there is some data that they have that says it probably is good. Again, I don't recommend, though, going below a BMI of 20.
Got it. Thank you. Well, now we have a bunch of questions on medications. So one question is, are there indications for these medicines, I presume the weight loss medicines, before a patient develop diabetes?
Yes.
In a pre-diabetic crowd.
Yeah. I'm glad you think that way, because that to me is what needs to be done. We need to be treating patients at a pre-diabetic stage. If we did that, we would avoid a lot of problems. People would live much healthier lives. They'd be out of the hospital. The overall cost would be much lower. But for some reason, you can't get approval for any of these meds with pre-diabetes. here's a really crazy part. If you want bariatric surgery and your BMI is 35 and they require you to have one comorbid problem, they will not accept prediabetes. They want diabetes. It's like, it's already too late, guys. So this is a mindset that I think, you guys might be able to get people to accept, because the data is very clear that if you treat the pre-diabetic, you're going to come way ahead in the end. Because once somebody gets pre-diabetes, it tells you they're not tolerating their weight. I will admit, not all overweight people are going to die early. A lot of them don't. They do fine. Usually Caucasian women who gain their weight in their hips and thighs, but not always. But once somebody you see pre-diabetes, that instantly predicts that patient is in trouble. They're not tolerating their weight gain, and they're going to run into problems.
Got it. So next set of questions about is medication discontinuation. The question is, if the patient has achieved their weight loss goal, can you discontinue the GLP-1s or the other medications?
So,
or are these going to be long-term?
Yeah, so you're right. You want to think of these as long-term. I will admit, a small percentage, maybe 10-15% of my patients actually come off their meds. They say, look, doc, I want to try it off it. Okay, let's give it a try. And 90%, they're back in about 3 months saying, yeah, let's get restarted. But about 10, maybe 15% can actually do pretty well without the meds. And in some situations, maybe even 20. But again, think of this, because the set point has been reset at this higher point, they're going to battle weight for the rest of their life. And it's tough to watch, because even in bariatric surgery, you do see this small creep in weight coming back 5, 10, 15 years out.
Got it. So there's a question about, do any of these medications, I think the questioner is looking at GLP, I think Sglt2 inhibitors, do they have an adverse effect on patients with peripheral artery disease?
No, yeah, I know. So you bring an interesting point, because this person obviously knows that because they excrete glucose into the urine, they're actually mild diuretics, and they actually lower blood pressure. And so in the very earliest of studies, they started to see in the studies for diabetes that some of the patients were having problems with their feet not getting enough blood. And it was because their blood pressure was dropping, and we didn't know that. We didn't realize these things are actually a combo drug, in that, sure, they help blood sugar, but they also help blood pressure. So, now that we kind of know that, you look at all the more recent studies, we haven't seen that in any of the big cardiovascular outcome trials, where they believe me, that is on their radar. They have to look for peripheral vascular disease getting worse. And now we're pretty certain it really was a side effect that was good, but we didn't know about it until basically we had a lot more, experience with the drug class.
Thank you. So based on this talk, there's a question about screening. The question is, what's your recommended way to diagnose prediabetes? Is it still measuring fasting glucose? Is there a role for postprandial insulin levels to assist in that diagnosis?
Okay, so the easiest way I do it is I'll just pull up the chart on the patient, because I'm a referral guy, so they get referred to me, and I'll just look at all their past chemistry panels and see what their blood sugars have been doing. And if I see any of their fasting blood sugars are 100 or higher, I'm going to check an A1C on that visit that I see them, because there's a high chance that A1C is going to be elevated. So that's one thing. Quite honestly, though, A1C in itself is actually a fairly good screening method, and I wish we used it more. Here's the tough part. Is if you have a patient who's Medicare, I'm assuming everybody here is in California, we call it Medicare, that they won't cover an A1C for a pre-diabetic, which just drives me nuts. So if you get one, patient's going to have to pay for it, which makes me upset. But anyway, long story short, A1C is very good. And I personally think we should test it in all overweight patients, because as I showed you the numbers, 1 in 3 Americans, that's a scary number. That's really high. So again, I think A1C should be checked with cholesterol in all patients.
Got it. Thank you. And any role for postprandial insulin levels?
There is, and that's a whole nother group. I'll go into my Asian studies. Obviously, I have a personal interest because that's my own problem. Is my postprandial A1C goes up pretty quick if I eat the wrong thing. You get this group that's very central, and they have these blood sugars that are right around 100, 99, 104. Their A1C is normal, but if you check their 2-hour postprandial, it's going to be elevated. It's going to be about 170, 180, which is bad, but they can get it back down because they either exercise so much or they eat really well, or both. So if you're suspicious, yeah, do it, because you're going to pick up this group that their 2-hour is elevated and they're at risk, because unfortunately, that's the one that's more damaging. As you know, a blood sugar of 105, 110 doesn't hurt anybody. But the minute you get a blood sugar of about 160, I'm guessing, that's when you start doing damage to blood vessels, the kidneys, all that other stuff that we don't want to happen. So, and I'm lucky. I mean, I had a lab, and I just, again, I'm near the end of my career. I'm trying to shut down my lab. I'm trying to stop doing research. I'm trying to just, enjoy life. But, I just run in there and just, you know what, let's do a 2-hour glucose tolerance test on me, so I can see those numbers. But again, in the patient that you kind of think, they look kind of at risk, don't be afraid to do it.
Got it. Thank you. So there's someone asking whether you can comment on terzipeptide. I hope I'm pronouncing it correctly. Terzi peptide. Okay.
Is that a medication, or is that triple hormone that they're building?
I presume it's the triple hormone that they're building.
Okay, that thing is going to be amazing. I mean, I hate to say it, you probably wouldn't have. You have to do some exercise. You'd have to eat reasonably well, but it basically will. And we kind of break things down into hunger and then satiety. So there's this drive to eat, that's hunger. So it'll control that. And then when you do eat a meal, your meal size will be small. So they'll have a peptide for that. But on top of that, they'll have the third peptide, which will probably be leptin, which will then keep you from lowering your metabolism. I mean, amazing stuff, but that's where they're going. Again, as you know, obesity medicine had the worst history imaginable. So many drugs were pulled because they just were not safe drugs. And so fast forward now that we finally understand why it's hard to lose weight, which hormones are incorporated, the science is just beautiful. And then, as you can imagine, the drug companies are going goo goo gaga over this stuff because it's the biggest disease they're ever going to treat ever. It makes diabetes look like a small disease.
Got it. A question back in prediabetes, is there a role for continuous glucose monitoring in that? What's your experience using CGM in pre-diabetic patients?
Okay, so we've looked at that. CGM is helpful to an extent. And it'll pick up all those patients that have the high postprandials. But the other thing is the patients they start to realize, I can't eat that. If I eat that donut, my blood sugar goes to 200. And so they get it, or they think, oh man, this smoothie, it's really healthy, it's really good, must be great for me. And they drink it and their glucose pops up to 200. So it really teaches patients about what they can and cannot get away with in their eating.
Got it. Could you please re-explain the metabolic set point information? Is it correct that if a patient gains weight gradually over time, the set point increases again? If the weight loss is achieved and maintained over years, will the set point reset to the lower weight?
Okay. So this has been tough. Let me see if I can find a picture here of my funny little drawings. No, whoops. Come on, where are you? I know you're here. Sorry, I hope you're not getting car sick. There we go.
We're hanging in there.
Okay, good. All right, so depending on how you gain your fat, but think of it as this way. So right here you have leptin, and leptin's continually feeding back to the hypothalamus, telling him how many fat cells are there and how big they are. And so it's the monitor. So whether you gain your weight in 6 months or you gain it over 20 years, you're going to start to increase the number of fat cells. Now, admittedly, and this is where we kind of struggle, are you gaining a lot of little fat cells, which are almost impossible to get rid of? And again, you can't lipo this stuff. It's deep inside. If you would kill somebody if you tried to lipo it. The peripheral fat you want, it's good. But the central fat, as it's feeding back, you're gaining more fat cells and they're getting bigger. So if you gain weight really quick, you actually do get bigger fat cells, big fat and juice. They actually begin breaking, and then they really create fatty acid problems. So admittedly, maybe, and this is all hypothetical, that the set point won't be set as high. But either way, the hypothalamus senses how much fat there is, and it will then set the set point up to that level of fat and fat cells. So, I mean, they're trying to do these weird gadgets of getting rid of visceral fat, but again, it's in the liver, it's in the kidneys, it's around the intestines, around the heart. It's so dangerous that no one's succeeded yet in doing it in a safe manner. So fortunately, it gets set up no matter what. So try and imagine this. You could have somebody gain weight at age 65, and guess what? Their set point's going to increase. The biggest problem is actually for women. And again, I'm not picking on women, but they have 3 points in life when they gain weight naturally. One is when they hit puberty, they'll start to put on fat cells. That's just part of the estrogen and all the other stuff. That's usually healthy fat. But the other one, which is more brutal, is when they have children. They get pregnant, they make more fat cells, and they don't get rid of those. And beautiful studies showing that the more kids they have, the more fat cells they gain, the harder it is to lose weight. But the big one is menopause. When they hit menopause, there's this huge drop in estrogen, huge drop in metabolic rate, and they start to put on fat cells again. So you can gain it at any time. Men, we just kind of gain it regularly through our life. Or if a lot of men keep their weight down through exercise. If they get injured and can't exercise, they'll pick up weight like crazy. I'll be curious to see if COVID, because a lot of people were dependent on gyms to exercise, and they couldn't go to gyms, and they gained weight. And is that going to be another contributor? Who knows?
Yeah, thank you. I just want to let the audience know in the Q&A, Jim Adams put in the reference for the effects of intermittent fasting on health, aging, and disease. The New England Journal came out a couple of years ago, so people can copy that for their purposes. Thank you. I think that's all the questions I have coming in. So let me open up to our panelists to ask any additional questions in the last 4 minutes. And by the way, there's a lot of thank yous in the chat to you, Ken. It's a wonderful talk.
Those I believe in the chats. Okay, let's read the chats. Okay.
Very interesting and great speaker.
Dr. Yu, could you talk a little bit about how the Scripps approach might vary from the Palo Alto approach, since you're two of the best performing medical groups in California?
Well, I think that at PANTH, the approach that we take is more, we use with people who are diabetic. We have the diabetes prevention programs to help them with that. Then when patients move into diabetes, we have set nutritional programs and diabetic educators to help them along their way. So that kind of ties into our previous speaker with Dr. Collings, where really, besides the medication part of it, really amp up and highlighting our patients to be aware of the lifestyle and particularly the nutritional aspect of that. So these are all pretty standard programs that our patients have access to, that we use together to help with them with a combination of lifestyle and medication approach. We don't have much coaching program in it. Part of it is just because We are in a model where reimbursement for those type of services is hard to make it work. Part of what we're doing is linking patients with external resources, of which that is of interest to them. Also, we are trying to digitize and use some digital platforms for that piece as well. So those are some of the things that we're doing in our space. But thank you, Hattie, for letting us share that information.
I see we have our statewide chairman, Bill Baumer, with us, who is at UC Davis, cardiology. Bill, did you have something you wanted to address with Ken Fujioka?
Of course I do. I always do. So Ken, great talk. Thank you very much. So the trial where they used semaglutide for obesity was a subcutaneous once a week injection. But for obesity, many of our patients are not yet diabetic, so they're not used to giving injections and things like that. Do you see any problems in the conversion of the oral semaglutide to obviously plasma levels that would make it not applicable to use the oral? Because I think taking a once a day or twice a day pill would be something that we could talk our patients into easily for obesity. And that's the perfect thing, you know, the pill that cures the problem. That's what everyone wants. And that they could avoid or would no longer need the sub-Q injection of the semaglutide.
I did one very small study years ago when we thought leptin was going to be available back in the 90s. And we just randomly did questionnaires to 200 patients to see if they would be willing to inject to lose weight. But the criteria was that the injection, the medicine worked. And I think it was like 99% of the women said, yes, I'll take it. One woman wrote in the comments, I'll even put it in my eye if it works. And the guys, it was still pretty high. It was like 91%. So it was pretty high and they were willing to do it. With that said, as you probably already know, they have already made one of the GLP-1s into an oral form. Right. So I would not be surprised if they do that with this. And you're right, patients really like the pill. I mean, you know, whenever I bring it up, I have to sit there and show them how to do it, because I'll lose them if they hear an injection. But once they see that it's, you know, it's just a sub-Q injection, it's really easy to do, they're pretty fine with it. But I'll be honest with you, I've lost a few patients because in COVID, it wasn't, you know, we went virtual. And so I wasn't like I could sit there and just grab it. Let me show you how it works. And before they could, you know, leave the room, I could stab them and they would say, oh yeah, it's not that bad. So just kidding. But, you know, I would not be surprised if they come out with an oral form pretty soon.
Yeah, so we can look forward tonight to having a glass of wine, a pill for a statin for our cholesterol, and a pill for obesity. And I think you've, you know, significantly improved our lifestyles.
Does that mean I can go back to having brownies?
Of course.
But not for breakfast.
This was absolutely fascinating. Really, really appreciate it. Obviously, there's so much more for us to learn from you. Dr. Emmons, did you have a final comment that you wanted to make? It's just great to have you back with us today.
No, this was fantastic. And I'm sure that we will make his slides available as we always do, because there is so much information in here. Many of us will want to go back and look at these slides again.
So Dr. Emmons, I might put you in touch with Dr. Fujioka so that you can just have a dialogue, doctor to doctor, to Southern California.
Will do.
Great leaders in this way, but I don't think we will be posting Dr. Fujioka's slides unless he's changed his mind. I learned so much, and I I'll probably be in contact with you, Dr. Fujioka, to ask you more questions. So I really appreciate your coming. We all so appreciate having met you through this and just expanding our minds about this disease process. It's been very, very wonderful educational session. Thank you, Dr. Fujioka.
My pleasure.
Happy surfing.
All right.
Yeah. Again, on behalf of the Right Kill Initiative Silicon Valley Leadership, thank you, Dr. Fujioka, for this great talk. And I think we're at time. So, Hattie, why don't you close it off for us and do you want to share the upcoming events?
I'll just invite you all back for a very special session we're doing with the U.S. Centers for Disease Control on Monday, April 12th from noon to 30, where we're going to be hearing from the founder of the cardiovascular disease section of the Centers for Disease Control, and also the current director of cardiovascular disease for the Centers for Disease Control, about our quest to get towards zero preventable heart attacks and strokes. So please look for that invitation and plan to join us. Dr. Fujioka, we welcome you to join us as often as you like, and we will be hearing from Dr. Jim Duddle, the former Kaiser national diabetes champion, about his proposal that we start using metformin sooner as part of our Get to Zero equation. Use that sooner in pre-diabetic patients. So that's going to be a very exciting session, noon to 2:30 p.m. on Monday, April 12th, with Janet Wright of the Centers for Disease Control and the very famous Darwin Labarth, who started that section of the Centers for Disease Control, along with our 10-year chairman of the San Diego University of Best Practices that we started with National Heart, Lung, and Blood Institute funding 10 years ago last month. So that'll be wonderful to hear from Dr. Demaria again and have a statewide session. So I'm excited about that, and I wish you all a very happy Easter and some good R&R. I'm going to stay on
everyone.
for those of us who want to do that, and just lovely to see you all, and thanks for all your help.